Hello, my name is Forson Chan, and I'm a first-year family medicine resident based out of the Victoria Family Medicine Center. This is a presentation about substance use disorders, and specifically, it's meant to prepare you for one of the 99 topics as specified in the CFPC exam. For the outline, I will only focus on subjects and information that will be relevant for your examination and follows the CFPC topic criteria. The outline is shown here, and the first topic that we'll be talking about is screening high-risk populations. So people who are high risk for substance use disorder can basically be separated into three different categories. People who are high risk usually have people who use drugs around them. Their life may have consequences which cause them to have difficulties, and they may participate in risky activities. People who use drugs around them include their partners or their families who have a history of drug use. And as part of CFPC learning, it's important to offer support to family members of substance abusers. And this might become relevant during oral exams. People who have difficulties with chronic disability, mental health, disrupted family and social relationships, or people who are doing poorly in work and school are also at high risk for substance use disorder. And it's specifically important to discuss possible substance use when adolescents are not doing well in school. Risky activities including those who are involved with crime or have a history of risky sexual history. In order to diagnose substance use disorder, we'll be following DSM-5 criteria. And so for one to be diagnosed with a disorder, one must be using a substance for a total of at least 1 year. In addition, here's a list of all the substances that fall under the definition of substance use criteria, and this includes alcohol, cannabis, hallucinogens like PCP or LSD, inhalants, opioids, sedatives, mostly benzos, stimulants like amphetamines and cocaine, and tobacco. Specifically, caffeine is not a substance that can lead to a use disorder. However, you can suffer from intoxication or experience withdrawal symptoms. In order to meet the definition of a diagnosis of substance use disorder, not only will you have to have drug use for 1 year using a specific substance, but you must also demonstrate other criteria, and the categories are impaired control, social impairment, risky use, and pharmacological criteria. And each of these sub-bullet points in black represent one criteria, and you must fulfill at least 3 in order to qualify for a diagnosis of substance use disorder. For impaired control, people usually use longer than intended, can't quit, spend a lot of time using or getting drugs, and often have single-minded urges or cravings. Regarding social impairment, some people may not be able to fulfill work or school obligations, and it's very important for the CFPC exams to consider substance use disorder if a person does not respond to medical therapies. It's also important to consider continued use despite problems and people who give up on activities as a result of their substance use. Other criteria include recurrent use when it's obviously dangerous, experiencing physical or psychological problems including psychosis or dependence caused by the substance, and pharmacological criteria include tolerance and withdrawal symptoms. So again, in order to be diagnosed with substance use disorder, usually if you have mild symptoms, then you have 2 of the 3 black bullet points in the previous line. If you have moderate symptoms, you have 4 to 5 symptoms, and if it's severe, you have more than 6 symptoms. There are also other specifiers for the diagnosis, which relate to early admission, sustained remission, maintenance, or the person is in a controlled environment where they are not privy to accessing substances. Also, what's really important but not part of the DSM diagnostic criteria is the state of change that patient is in, whether they're pre-contemplative, which means that they are not thinking about quitting, if they're contemplative, where they're thinking about quitting, preparative, where they're planning to quit, including making visits to physicians in order to discuss substance use, action phase, which means that they are in the active process of quitting, the maintenance phase, where the patients are have already quit and are trying to stay off the substances, and the relapse phase, which is unfortunately more common than we would like. The management of secondary issues related to substance use is a big part of the CFPC exam criteria, and I'll be specifically talking about a few diseases and a few comorbidities that are associated with substance use. Firstly, I'll talk about screening for bloodborne illnesses in IV drug users, and specifically I'll talk about hepatitis B. When ordering testing for a person with substance use disorder, and you want to do hepatitis B testing, there are 3 tests that you'll be ordering. The first is a hepatitis B surface antigen, and this is positive if you have an active infection. If it is positive, then it is reasonable to retest after 6 months to see if it is chronic in nature, and it may not necessarily need immediate treatment if it's a first-time exposure. Secondly, the thing you want to test for is the hepatitis B surface antibody, and if you are positive for this, it means that you have lifetime immunity and there's no further testing indicated. Lastly, if you have the hepatitis B core antibody, it means that you've been previously or currently exposed to the hepatitis B virus. To the right, you can see a chart looking at the combinations of the test results that is possible with these tests. Of course, if you're negative for all of them, it means that you've never been infected and you're currently not infected. However, it is possible to get infection in the future, and it's important to advocate for the patient to get the hepatitis B vaccination. If they are positive for the hepatitis B surface antibody and the core antibody, it means that they have immune protection and they have also recovered from a prior infection, as the core antibody is also positive. As a result, you do not need to vaccinate these patients. For patients who are only positive for the hepatitis surface antibody, it means that they are immune to the virus and no vaccination is needed and no further testing is needed. Finally, if the patient is positive for the hepatitis B surface antigen as well as the core antibody, it means that the patient has a hepatitis B virus and needs further evaluation, including a retest in 6 months to determine if this is a chronic disease. If it's an acute infection, then most likely the hepatitis core antibody it will be negative. The second disease we'll talk about is HIV, and the testing for this is pretty straightforward and includes PCR or the NAT or the NAAT test as you'll write it on your requisitions for testing for HIV. For hepatitis C in particular, you will be doing the first test, which is the hepatitis C viral antibody test, or the HCV-AB, as you would write it on a requisition. If this test is positive, then you would need to proceed to do a hepatitis C viral RNA test. However, if this test is negative, it is reasonable to retest in 6 months, especially if the patient continues to be engaged in risky behavior or IV drug use. When you're doing the hepatitis C RNA test, if it is positive, then you conclude that the patient does have chronic hepatitis C. If it is negative, then you retest in 6 months if you are suspicious. If you retest it after 6 months and it continues to be negative, then you conclude that the infection is cleared and the patient does not have a chronic infection, but the patient is susceptible to reinfection. And if there is continued risky use, you may still want to retest for hepatitis C in 6 months. Vaccinations are also a big part for patients who have substance use disorder. As standard of care, we offer yearly influenza vaccinations. For hepatitis C, the vaccinations are covered if they are active IV drug user or if they are a man who has sex with other men. It's also covered if patients are hepatitis C or hepatitis B positive. You'll be administering 2 doses, and the second dose is usually administered 6 to 30 months after the first. You would also want to check for hepatitis B and offer vaccination if they are not already immune. And also, if they're HIV positive, you can also offer the pneumococcal pneumonia vaccination, and it will be covered under ODSP. Finally, for management of secondary issues, you want to screen for comorbidities and complications related to substance use. Specifically to IV drug use, you want to look for skin and soft tissue damage, including cellulitis and track marks in the lower legs. For patients who have cocaine use, you want to examine the nasal septum for perforation. For patients with, for generally all patients, you want to examine for cardiovascular, pulmonary, GI, STI, mental health comorbidities, and these are listed here. And so in your physical exam, you want to make sure that you listen to the heart, you take a blood pressure, you do screening for hypertriglyceridemia, which is associated with alcohol use. You want to screen for endocarditis if they are active IV drug user. You want to, if they are a smoker or in environments that are often filled with smoke, you want to screen for COPD and TB if you are suspicious based on your clinical exam. You want to do an abdominal exam, including looking at the liver and the pancreas. And you want to ask for urinary symptoms and genital urinary symptoms in order to be paying watchful eye out for HIV, syphilis, gonorrhea, and warts. Patients who have substance use disorders also have oftentimes comorbid mental health issues, and of course you want to do your screening for that during your primary care visits. The next big topic I want to talk to you guys about is management of intoxication and withdrawal symptoms for all the substances. The firstly being alcohol. Alcohol is an important topic because there's a lot that we can do in order to improve patient outcomes. With intoxication, the standard laboratory results to order include electrolytes, a glucose, and a blood alcohol level. The management is largely supportive if you've ever had a friend with intoxication. However, once a patient becomes unconscious and presents to the emergency department, the typical standard of care is treatment with thiamine, 100 milligrams PO daily, which helps reduce and prevent Wernicke's encephalopathy from this vitamin deficiency. And in order to diagnose Wernicke's, they're usually a triad of encephalopathy, gait ataxia, and nystagmus. You also want to give IV fluids for rehydration, and dextrose, as they may be hypoglycemic, but only give this if they are hypoglycemic. If they do demonstrate evidence of Wernicke's, then you want to treat with a higher dose of thiamine at 500 milligrams TID for at least 2 days, followed by 250 milligrams for 5 days. For maintenance, as an outpatient, when they are not acutely intoxicated, it may be reasonable to have the patient be on regular thiamine and folic acid. For alcohol withdrawal, where they have abstained from alcohol for a specific period of time, the most important thing you want to do is you want to prevent delirium tremens. And the symptoms include hallucinations, disorientation, tachycardia, hypertension, hyperthermia, and diaphoresis and agitation. You can predict the incidence of delirium tremens using a PAUSE score. And this looks at a variety of risk factors, including a previous history of delirium tremens, if they're over the age of 80, and if they have a history of withdrawal seizures. These are the main things that you want to look out for, as well as the symptoms of delirium tremens on previous withdrawal events. These delirium tremens usually occur 2 to 4 days after the last drink, and the duration can last 1 to 5 years. While their patients are in active withdrawal, the use of benzodiazepines can help ease their transition and also prevent delirium tremens. Specifically, the CWAT looks at nausea, vomiting, sweats, and tremors being the objective criteria of a patient's withdrawal symptoms. And there are some other symptoms listed here which are more subjective to the patient. So if the patient is an unreliable historian, it may be applicable to only look at the objective scoring criteria and treat accordingly. Looking at both subjective and objective criteria, if the patient has a score greater than 8, then we usually start treatment with diazepam 5 to 10 milligrams IV, or lorazepam 2 to 4 milligrams IV. Or alternatively, if the patient is tolerant, you can also use oral dosing. As an outpatient, for patients who will be discharged to a detox facility, for some patients, it may be reasonable to give them a prescription for diazepam, 10 milligrams TID, PRN for 3 days, and this will help them to ease their withdrawal. It is not suggested to give a prescription for patients with active alcohol use disorder, and if you've given them prescriptions of this in the past where they haven't successfully entered treatment in the facility, as the use of alcohol and benzos together can lead to dyspnea and decreased activity of breathing. The next substance we'll talk about is the use of cannabis. Intoxication includes a variety of symptoms, including tachycardia, agitation, dry mouth, and increased appetite. Treatment is mainly supportive. You could give a little bit of benzo in order to ease their symptoms while they're intoxicated, and while they're in withdrawal, you could give them a little bit of gabapentin or zolpidem to help with their sleep and withdrawal symptoms. However, for the most part, it does not require treatment. For inhalants, again, these include nitric oxide, gasoline, and toluene, which is found in paints. And you want to test for CBC electrolytes and blood gases. And this is because these inhaled gases have a possibility of putting you at risk for methylmoglobinemia, and treatment is the use of methylene blue. With patients with toluene inhalation, they may develop hypokalemia. For hallucinogens, you can give some benzos to calm them down, but again, the treatment is mainly supportive and the patients resolve on their own. Opioids are a particular focus because they can lead to patient death, and the main management is to focus on the patient's respiratory status in order to make sure that they continue to maintain oxygenation. On the street, if you have a naloxone kit handy, you can give the nasal sprays, which contain 4 milligrams of naloxone, and you administer it every 2 to 3 minutes. If you have the IM form, you give 1 milligram IM every 2 to 3 minutes. For patients who are in withdrawal, then what patients can decide to do is that they can continue to use the substances on the street. However, if they're planning to stop their substance use and want to transition to something like Suboxone, then it may be appropriate to give them a dose of hydromorphone in order to tide them over for the next day, and you want to give half the reported morphine equivalent dosing. For their symptoms, you may also want to offer clonidine and Gravol for nausea and withdrawal symptoms. And also, while they're in active withdrawal, you can also give them Suboxone and methadone to start them on an opioid agonist treatment. Now, for patients with benzo intoxication, the antidote for benzos is fluminazole, which is 0.5 milligrams IV, and you want to repeat this every minute to a max dose of 3 milligrams if the patient does not respond. They may also require additional doses as the half-life is only 1 to 2 hours. For withdrawal symptoms, you could, if they have a benzodiazepine use disorder, you can give them more benzodiazepines. And specifically, the best one probably to choose would be diazepam, as the half-life is 2 to 3 days, and the medication will titrate itself off on its own, and you don't need to follow up. You don't need to give a complicated script where they take decreasing doses of short-acting benzodiazepines. For intoxication with cocaine, again, the management is mostly supportive. If you end up having to give an oral airway, put in the trach, and you want to use a paralytic, then it's important to use rocuronium and not succinylcholine, as succinylcholine can prolong the effects of the cocaine and also the duration of paralysis. If they are undergoing an event like a chest pain or an MI, it's important to avoid beta blockers as standard of care. However, the latest evidence shows that this is a bit controversial, and it may be better to use phentolamine and nitroglycerin instead to reduce blood pressure and reduce chest pain. Specifically for cocaine-associated chest pain, you can give benzodiazepines when patients use cocaine. And this is not true if they have any other related chest pain or if they are coming in for a regular MI. Specifically for cocaine use, you can give benzos, and it is standard of care. Also, patients with cocaine and is associated with hemorrhagic alveolitis, which has symptoms of cough and shortness of breath, but the management is mainly supportive of O2 and supportive management. Next, for nicotine use disorder or smoking, there is no intoxication associated with it, and the treatments include NRT or nicotine replacement therapy, varenicline, bupropion, and the coverage for these treatments is 3 months only, and they can try it once a year. Next, I'll be covering topics about treatments of different substance use disorders. And from here on out, these are specifically not CFPC exam topics, but who knows, they may appear on the exams. They are, the talk that I'll be giving starting from here would be relevant for clinical practice though, so if you're interested, then you can continue listening and watching. For treatment of alcohol use disorder, there are 3 substances that are evidence-based. They are naltrexone, acamprosate, and antabuse. Antabuse is no longer covered, and so I won't cover that anymore, but historically it was a go-to treatment for alcohol use disorder. When consumed, it would cause them to have a reaction where they become violently ill, and this is supposed, and it will dissuade patients from continuing to use alcohol. For patients with alcohol use disorder have historically been separated into 2 groups: patients who have who take alcohol in order to feel better and to get away from their depression, or patients who drink alcohol in order to binge drink and they enjoy the euphoric effects. For patients who enjoy the euphoric effect, naltrexone is usually the better drug of choice, and however, it's contraindicated in severe liver disease or patients who are actively taking opioids, as they'll put them into precipitated withdrawal. Acamprosate is a good choice if they've already abstained from alcohol for at least 3 days, and it's good for patients who usually use it in order to cope with their mental stressors, as it has GABAergic effects as its mechanism of action. Patients with opioid use disorder have 2 treatments available, and the best treatment available is Suboxone. You want them to have cease opioid use for about 12 hours prior to the morning of the induction date or the start date of the Suboxone. You can give 1 dose of hydromorphone for the evening prior in order to help time them well in order to start on regular treatment. In addition, alternatively, you can give them clonidine, Gravol, and loperamide as PRN prescriptions in order to get them through the side effects of opioid use disorder withdrawal. You want, in order to see if they're in enough withdrawal, you want to do a CAL score. And what a CAL score is it's like the CWA, where there are a variety of symptoms that are measured to see if they are in active withdrawal. And you want to make sure that they are deep in withdrawal before you give Suboxone in order to avoid them going into precipitated withdrawal, which is when they start to suffer the extreme symptoms of withdrawal. So you want to give so when they have a CAL score of greater than 12, you can give the first dose of Suboxone, which is 4 milligrams of buprenorphine. And after 30 to 60 minutes, if it helps and withdrawal is not adequately relieved, then you can give more, up to a maximum dose of 12 milligrams of the buprenorphine on day 1. On day 2, you can increase it up to 16 milligrams. And the target dose is usually 12 to 24 milligrams sublingual. The max dose of it is 32 milligrams. For methadone, for patients with opioid use disorder, you want to start them on a starting dose of 30 milligrams PO daily. And the titration is very slow, and as for some patients, it can be too slow. However, and that is the advantage of Suboxone, where they can reach therapeutic dose within 2 or 3 days at most. You want to increase it by 5 to 10 days every 5 days as an outpatient, but when they're an inpatient, you can increase it as quickly as every 3 days. For acute pain, sometimes the methadone can be split BID or TID, and this helps improve pain control actually. If they miss 3 to 4 days of dosing, you must restart them at 50% of the previous dose, as you could cause them to go into an overdose situation if you give them their regular dose. If they miss more than 5 days of methadone, you restart them on 30 milligrams daily. Other treatments include long-acting oral opioids and supervised injections, but these things are not very popular here in Ontario right now. For nicotine use disorder, I think everyone is quite familiar. Varenicline is probably the most effective choice. However, it's associated with vivid nightmares, and bupropion is also a very good choice, and it's especially good if the patients have a history of depression or obesity. However, if the patient has an eating disorder, you want to avoid using this medication. Particularly for Wellbutrin, if a patient has active depression, then you can prescribe this for years and years, as opposed to varenicline, where you can only prescribe for 3 months out of a year for a patient to get ODB coverage. For nicotine replacement therapy, oftentimes we're aware that you can prescribe lozenges, inhalers, and gums, and sometimes it's difficult to know how much of the patch to give, but here's you can do the brief Storm test, which asks the patients how soon do they take a cigarette after waking up, how many cigarettes they smoke per day, and then it assigns them a score in order to determine the best dosing of the nicotine replacement patch. And you want to follow this closely in order to determine, in order to follow their cessation from smoking. And I'll let you look at the slides on your own. Finally, for marijuana, which is a topic that we often request lecturers to talk about, but they never actually do. I'll talk a little bit about the treatment and management and how to prescribe marijuana. For chronic use of marijuana, it has a bunch of negative side effects that's important to educate the patient about. And these include cyclic vomiting syndrome, where they have constant vomiting after marijuana use, or sometimes days after marijuana use. It can unmask schizophrenia and psychosis. It can induce psychiatric disturbances, and it can also impair memory, cause gait disturbances, and also impair driving. For prescribing marijuana products, probably the most common product we prescribe is Nabilone, and it mimics THC, which is a psychoactive substance, and also has some benefits with pain control. You could prescribe it between 0.25 to 0.5 milligrams PO/QHS, and a usual dose is 1 to 2 milligrams daily, or BID. The max dose is 6 milligrams per day, and you want to increase it slowly and titrate it to effect. The cost for the patient is approximately $30 to $100 per month. Another prescription that is possible is the THC CBD spray, which is sublingual, and you can administer it start administering it 1 to 2 milligrams PO BID to TID with a max dose of 6 milligrams per day. Mainly, the benefits are to reduce nausea and vomiting. However, some patients report that it does have some benefits with pain control as well. It is not covered under ODB, and if patients want it, it can be quite expensive, with a 3-pack vial costing $700. CBD oil contains a cannabidiol, which is less psychoactive than THC. And you can prescribe it as 2 to 3 milligrams CBD for start of treatment. For cancer type pain, the effective dose of CBD is about 2.5 to 10 milligrams daily. And for the THC component, usually therapeutic doses after titration is 15 to 20 milligrams QD. Unfortunately, the evidence behind marijuana is very, very poor, and it is really unclear at what doses and how quickly you should titrate the marijuana in order to obtain adequate pain and symptom relief. And so it is still quite a black box, and partly a reason why lecturers probably haven't given us lectures about this. So here are some references, specifically if you want to look at this ARCS files document, you can obtain some information about use of marijuana. Other reference materials are available here, and I hope you have a nice day. Thank you.